Okay, good evening. So this is going to be the second part of Polycystic Ovarian Syndrome webinar. And before I start, I would like to wish all of you a happy Teachers' Day. Today is a very special day for all teachers. It is a day for remembering our past president, Dr. Radhakrishnan. And also, I would like to tell you my favorite quotation on Teachers' Day, that learning is finding out what we already know. Doing is demonstrating that we know it. Teaching is reminding others that they know as well as we do. We are all learners, doers, teachers. This is by Richard Bach. So we are all at some stage of learning and some stage of doing and some stage of teaching. So that is a wonderful thought. Once again, my disclosures. All of you know I'm an anesthesiologist, and in my daily life I practice high-end cutting-edge medicine. But not only that, I also try to get to the root of this metabolic problem that is become a pandemic all over the world. And as I have described you in my previous webinars, I had a personal experience with becoming sick and then getting well again by sheer uh, diving into the science and doing it not the conventional way, but by not by medicines, but by diet and nutrition and lifestyle changes. So that is the evidence I would like to share with you. I'm also listed as a low carb specialist, a diet doctor, and as a lifestyle coach in these international websites. But I do not get any financial remuneration from them. So once again, these webinars are for your informational purpose only. What I'll be sharing here is designed to help you to make informed decisions about your health. It is not intended to serve as a substitute for your professional medical advice, mind you, especially about medications. And if you are on medicines, please do not start or stop any medications listening to me. You have to work with your doctor. And it is possible that your doctor may not agree with what I am saying. So that is why these webinars, where like SCP forum, where there are as many doctors as many people from the general population, and the message goes out to everybody. And if you have to, you can just inform that such a thing is possible, and you can also quote the references which I give you. My talks are always full of evidence. So with those evidence, you can work with your doctor to make the changes in your life which you want to. Okay, so this is the paradigm which I started with. Uh, that the root cause of all metabolic diseases is insulin resistance. So whether it is uh, excess body fat or heart disease or Alzheimer's, diabetes or PCOS, which we are discussing now, unless you treat the elephant in the room, the big thing in the room, which we don't see, there is no point, chasing after all the small things. So last time I told you that as far as PCOS is concerned, the data from our country is very alarming. 1 in 5 women in India suffer from PCOS as compared to 1 in 10 all over the world. Not only that, this is a very nice study of in social science and medicine, which the study has been done in Mumbai and published from the University of Arizona, and they have studied PCOS in middle class urban living population, and they have come up with some very good practical conclusion that rather than emphasizing genetic predisposition, popular and medical discourses PCOS in India highlights the changes in lifestyle of the urban middle class following economic liberalization, particularly disrupted meal and sleep routines and new stresses on women resulting from competition for education and jobs, consumerism, and juggling responsibilities of the home and work. This is what has led to a totally altered lifestyle and a lot of stress. So much so that we are now the PCOS capital of the world. This I showed you last time also. And I also told you last time why PCOS patients are very, very vulnerable to the COVID-19 pandemic. And this is a completely overlooked female patient population which are at potentially higher risk. Why is that so? It is because the risk factors which increase the, look at this yellow circle, these are the risk factors which increase vulnerability to the COVID-19 pandemic. That is obesity, hypertension, type 2 diabetes, metabolic syndrome, ethnic manner, some groups, high cytokine levels, high androgen levels, and low vitamin D levels. All these factors coincide with patients of PCOS who have who very often have these symptoms. So that is what makes them more vulnerable to the pandemic. So this is was my summary slide last time, and here you can see on the right hand side are the diagnostic criteria of polycystic ovarian syndrome according to the Rotterdam criteria. And on the left hand side, you can see what I had come to is this high insulin or insulin resistance, which causes all this, the root cause of all these symptoms, which is also this high insulin could be due to many causes, which I told you it could be due to, mainly due to insulin raising diet and obesity, which we'll come to. Now, here is a patient, typical patient, two types I will describe to you. Her name is Hina. She is a 28-year-old woman who has come for evaluation of PCOS, obesity, and insulin resistance. She started her periods at the age of 12. Her periods were monthly and regular initially. But by the age of 16, she gained 36 kgs from 12. And her periods decreased to once only every 9 to 12 months. She also developed clinical depression, and her doctor attributed her infrequent periods to depression. She received no treatment for her irregular periods. Her weight increase continued over the years. 3 years ago, when she was 25 years old, she went through testing for PCOS. Her blood test showed a high testosterone. She had been taking birth control pills since then. Her facial hair started to grow when she was 18 years old, around the chin and the neck area, and requires waxing every 2 weeks. She does not have any excess hair on her body and is not losing any scalp hair. She received no medical treatment for excess hair. Her weight is now 118 kgs. Now she has followed several diets, not that she has not tried. Every time she lost weight, but then she again regained it. She loves to eat ice cream once a week. She likes sushi, she eats potatoes. Although she reduced the amount of juice and soda, she's not following a strict low carbohydrate diet, and she's not exercising either, and she has never been on metformin. But she has a strong family history. Her father has type 2 diabetes, her sister has type 1, and her great grandmother had type 1 diabetes. So this is one kind of patient you get. Another is a slightly elderly patient, Meena. She's 33-year-old who is now planning a family, and she wants to get pregnant, and she presented with PCOS and obesity. She had her first period at the age of 12 once again. Her second period came 2 months later, and her third period did not come for another 6 months. Now, until the age of 20, she had periods approximately every 6 months. Between the age of 20 to 25, she used birth control pills and had monthly periods. At the age of 20, she stopped the birth control pills and to try to become pregnant, but did not have any periods. 2 years ago, she received clomiphene, that is Clomid, for 4 cycles and letrozole for 1 cycle. Next, she had in vitro fertility. Because that didn't work, she had to go in for IVF, and she became pregnant, but miscarried at 18 weeks. She did not use metformin during her infertility treatment. Now she has severe hirsutism on her face, chest, back, upper arms, abdomen, and legs, and shaves her face and body daily. And she is 5 feet only tall, and she used to weigh 68 kgs. But 2 years ago, her weight has increased to 78 kgs. She has maintained this weight since then. She has also developed glucose intolerance, and she has been taking metformin intermittently. On metformin, her hemoglobin A1C was 5.4, but when she stopped, it went up to 5.9. She has 9 siblings, including 5 sisters. 1 sister developed type 1 at age 11. None of her other sisters has gestational diabetes or type 2 diabetes. So this is another kind of patient which you get. Now what happens is, whatever the patient comes, These are the diagnostic tests which are done: AMH, testosterone, and free testosterone, and hemoglobin A1C. Sorry. So these are the tests done to rule out, and some special tests, and some tests which are not very optional. So what happens next is, this is the normal range, and this is what you get patients, this kind of patients results. So SSBG is low, testosterone is high, and AMH is high, HbA1c is pretty high. So this is the kind of laboratory results which you get. And usually what is prescribed, most of the doctors, they try, they just tell you, okay, you must do some lifestyle changes, you must, lose some weight, you must, eat less, and you must exercise more. You must not take sugary food. So some kind of advice, lifestyle advice is given. It is not that it is not given, but the problem lies somewhere else. So this is the lifestyle management advice which is given usually to most patients: lose some weight, and some people hand out a PCOS diet chart, which is usually the conventional diet chart, which gives you low fat, whole grains, fruits, vegetables, and multiple servings throughout the day. And they tell you stress management, improve sleep quality, do meditation. But this kind of advice, unless you really go to the root cause and give very practical way to have a very practical way of doing it, it usually doesn't work, and the patients get frustrated, and then immediately the next step is to go for medication. So so this is what we excel at. This is the modern day treatment. I showed you last time also. You have symptoms. All these are the symptoms on your left, and these are the diagnostic tests. Nowadays, ultrasound will immediately detect, and your pelvic laparoscopy you can do. You can, hormonal tests, as I told you. Okay, treatment is fertility drugs, just weight reduction, very well told, but cannot be followed. So first line of treatment is birth control pills, and then otherwise, if you want to become pregnant, fertility drugs. So all, medicines, and then the ultimate IVF. So this is what is the mainstream medicine conventional treatment. So I've made it simple for you, and I will go through of these one by one, just for your knowledge, and why these work and why they don't work, and why they actually do not work. So I'll let you know. So we'll start with the birth control pills, also known as oral contraceptive pills. It's actually a hormonal contraceptive, typically containing a small amount of estrogen and progesterone hormones, and it has been the mainstay of drug therapy for PCOS for decades. It comes in a variety of formulation and remains one of the most applied treatments. So these drugs, it is the best way, to start treating menstrual irregularities. They reduce androgen levels, increase liver production of sex hormone like SHBG, which reduces the symptoms such as acne and hair loss. However, successful treating the symptom, the birth control pill treats PCOS. It does not treat the root cause, that is hyperinsulinemia. If you stop taking BCPs, your symptoms will reappear, and you are always at a higher risk of blood clots. Although the fourth generation progesterone pills do address that, and they really reduced the incidence of blood clots, but the risk factor for blood clots remain if you are taking oral contraceptive. Another next drug which is given is spironolactone. Spironolactone is a dry diuretic actually used for hypertension patient, and they block the action of androgen at the level of the receptor. So it actually does not reduce the androgen level, but it blocks them from having the full effect. So facial and body hair may be reduced by up to 40%, but again, the symptoms will return once the drug is stopped. That is the big problem. And once again, it does not address the real underlying cause condition of hyperinsulinemia. Now, spironolactone has several side effects. Like it causes, we call it as doctor hyperkalemia. That means the potassium level frequently become elevated, and this could be dangerous. It is also teratogenic. That means it can cause birth defects during pregnancy. So it just can't be used during that time. Since PCOS often affects women in the reproductive years, spironolactone must always be used with birth control pills. So, absolutely no way that this particular drug should be exposed to a fetus or a concept or a conceived child. The other drug, which is hailed as a magic drug by the medical world, is metformin. It's actually a anti-diabetic drug, and the property which makes it so famous is that it improves insulin sensitivity, and thus can reduce the underlying hyperinsulinemia which causes PCOS. So that this started in the early 90s. We showed that metformin can reduce both circulating insulin and testosterone levels. Lower insulin levels reduce the production of androgens, which is the hallmark of PCOS. Later studies confirm that metformin could reduce circulating insulin by 35%, which improved every aspect of PCOS and also increased the chances of ovulation and conception. So metformin was actually hailed as a magic drug. So a lot of studies, which I will not go into the details, which kind of supported the use of metformin because it improves insulin sensitivity. So it also has a lot of side effects that the literature mentions mild to severe, and some ladies just cannot tolerate metformin. That becomes the issue. So so that became the mainstream medicine. But when most of these studies of metformin were individual studies which showed the benefits, but when meta-analysis in medical science, we call it a study of study. This is a meta-analysis done by Cochrane. Cochrane is one of the most prestigious database where what we follow. When they showed that these drugs, metformin, proglitazone, even inositol was taken into account, and they showed that they went through 48 randomized control studies, and they said that metformin may be beneficial in improving the chances of a live birth. It is not clear from the available evidence whether metformin or clomiphene citrate is superior for live birth rate. Although pregnancy and ovulation rates are improved, the women taking clomiphene have fewer side effects. But metformin actually does not increase the miscarriage, but it is not this. The analysis of studies does not show real benefit as claimed by the individual studies. So they have concluded that the limited improvement in metabolic outcomes with metformin highlights the importance of weight loss and lifestyle adjustment, especially in overweight women. So they have again gone back to the importance of weight loss and lifestyle adjustment. So actually, there are a lot of reasons not to take metformin. That metformin causes weight loss is a myth. There are several reviews which have shown that metformin doesn't help with weight loss and only causes slight improvement where your excess body fat is located. So this is the problem, and it is just a band-aid solution. That is what we call it, and that is what the Cochrane study also showed. And it really does not help with PCOS infertility, and the side effects many of the ladies cannot handle. And moreover, the most important reason is that there is a much better alternative that will come to after some time. Okay, so another group of drug which has been which has been a lot of extolled and become very popular in the recent past is known as the group which is known as the inositols. Now, inositol, I would like to tell you some detail because it has become a rage to prescribe inositol. It is actually a group of natural sugar-like compound which is already there in the body and found in fruits and beans and nuts. So there are two forms, that is MI. MI is myoinositol and DCI is D-gyroinositol. Now what happens is they play a role in glucose uptake, and the DCI plays a role in glucose and glycogen synthesis. So, and because they are they are known as second messengers to insulin, and because of their insulin sensitizing effect, they successfully improve metabolic and reproductive aspects of PCOS. Now, this has been shown in many studies. So that is why it has become very popular. I will just, so there is a formula which is the two types of inositol, that is MI and DCI. The combination 40:1 has been found to be most effective. So there are many studies. I will just show you, but not go into the details, because this is why there are so many studies. And this is once again a meta-analysis. So they have shown that there is a slight trend towards reduction of testosterone concentrations, although androstenedione levels are unaffected. A significant increase in serum SHBG, which helps. So, but what it does not do is it does not help you to reduce weight. So women, there is no change in hip to waist ratio. Women who were moderately overweight lost only 2 pounds. 2 pounds is less than a kg. So body weight is unaffected. This is what it does not do. This particular ratio, other studies have shown that it could be just arbitrary. So it is that maybe more research is needed. So the take-home message is that it is still very early days in the research of using inositol supplement. It is, mind you, a supplement. So, and they are second messengers to insulin, as I told you. And if there is chronic hyperinsulinemia, which is the root cause, and insulin resistance, the effect of the inositols will be impaired. So still very early days, though a lot of enthusiasm about inositol, but one has to be a bit careful. But one good thing about inositol is it doesn't have much of side effect, so can be tried out. What about surgery? Last time I told you about Dr. Stein and Leventhal, who used to do ovarian wedge resection, and that which is rarely used today because of the new fertility drugs which have come. So, but even nowadays, when all other options fail, doctors may use the less invasive laparoscopic ovarian drilling. But the idea is, by surgically removing small wedges laparoscopically, the ovary is less able to make testosterone. So this reduces the symptoms of PCOS. But however, once again, this is the problem. The underlying problems of excess insulin is not addressed. And the complication rates of surgeries are unacceptable because it is a very invasive thing. So that is why it is not popular and it is not done. And it could leave us excessive scar tissue and may not be successful also. That the studies have shown. So the next is the fertility treatment. For as long as a lady suffering from PCOS is not trying to get pregnant, birth control pills can help to some extent. But once fertility issue comes in, there lies the problem, because the PCOS condition is such that it hampers ovulation and hampers conception. So the number one drug, which is very popular, which has been there for quite some time, is known as clomiphene. Now this selectively affects estrogen receptors. It is the problem with clomiphene is the success rate is only 5.6% per cycle. And with treatment means you have to give some gonadotropin, try to make ovulation happen, and then give clomiphene. So all these combinations and permutations are done. So, but it was successful when it was launched. So this success revolutionized fertility treatment, in fact. And it, at least one good thing it did, it completely replaced surgery for PCOS, because it is both relatively inexpensive and highly effective. But it does have limitation. It does not work if it does not work in the first few months, it will never work. And you must move on to other treatment. And combining clomiphene with other drugs like metformin also does not make it more effective, although people have tried many combinations. So despite these cautions, clomiphene is still considered as the first choice medication for the treatment of anovulation, underscoring the fact that how little progress has been made since it was launched in the understanding of the disease in 1960s. So all we still have clomiphene now, nothing more than that. And other new drugs are just coming in, but research is still to be done. So the other drug is which came later on is letrozole. It belongs to a class of medication known as aromatase inhibitors, which kind of stimulate ovulation by preventing androgens in the body from converting to estrogen. As I told you last time, uh, all estrogens were once androgen, and this aromatase enzyme converts the testosterone into estrogen. So if this is blocked, what happens is um, the stimulates the pituitary to produce FSH, which stimulates the ovary to produce an egg. But compared to clomiphene, letrozole produces a more physiologic hormone stimulation that has fewer side effects and a higher rate of live births. But the major concern is, although the results are not statistically significant, some studies show a higher rate of serious birth defects. So that is the risk which many women and their doctors are not willing to take. So there is a serious risk factor over here, increased incidence of birth defects. The gonadotropins are injectable hormones called, and they can stimulate ovulation by mimicking the normal pattern of FSH and LH, which helps the follicle to mature and increase the chances of ovulation. The ovulation rate of women with PCOS, including gonadotropin, is actually 70%, and the pregnancy rate is 20%. So sounds pretty good, but the main drawback is the risk of multiple pregnancies, which is as high as 10%. So there lies the problem. So another very big risk with gonadotropins is something known as OHSS, which is ovarian hyperstimulation syndrome. What happens is the ovary gets very much stimulated because we are using a powerful hormone, which can range from mild, which causes abdominal distension, gastrointestinal discomfort, to severe, like enlarged ovaries and decreased urinary production, blood clots, and even critical, it may even cause death. So OHSS is a potentially serious risk anytime there is ovarian stimulation, but its prevalence depends on the treatment being administered and the individual. So a lot of expertise is needed. This can't be done anywhere. So this is a serious risk with administering gonadotropin. So the next and the treatment are the invasive ones, known as IUI, intrauterine insemination, which is the less invasive of these two and less expensive. So what happens here? A woman is given injectable gonadotropins once again to stimulate ovulation every few days, blood tests, and every few days blood tests and intravaginal ultrasounds are performed to monitor the number, growth, and maturity of the follicles. So you have not only have to give gonadotropin, you have to monitor the growth of the follicles. So once the follicles mature, an injection of another HCG is given to further mature the egg and promote ovulation. So if ovulation occurs, a catheter with sperm is inserted directly into the uterus to ensure that adequate sperm is available when the egg is maximally receptive. So over the next few weeks, the women resume normal activities and wait for signs and symptoms of a possible pregnancy. So success rates are around 20%, slightly lower than with the IVF. So, but the problem is IUI still requires ovulation to be successful. And mind you, in PCOS, one of the problems is that ovulation does not occur. So it is quite an invasive method, barely about 20% success rate every time you try, and requires a lot of monitoring and technology. But then so is IVF, which is the ultimate thing to do for fertility, where modern technology takes over as much of the baby making process as possible. So first gonadotropins are injected to stimulate the eggs, and instead of relying on normal ovulation, mature eggs are retrieved surgically via ultrasound guided needles. And then you combine the sperms with the eggs in a petri dish in a laboratory, and then successfully fertilized eggs are then transferred back to the uterus. So with some luck, an embryo will implant in the wall of the uterus and develop into a growing fetus. So this is ultimate, you use technology to get a baby as by any means. So the concerns over here is, number one, the physical discomfort, no doubt. The success rate is very difficult to measure, and it can range widely depending upon the woman's health, age, reproductive history, and lifestyle. But anything between 13 and 43%. Once again, the concerns are there. that ovarian hyperstimulation syndrome can occur. There could be multiple pregnancies, there could be infection, and it is very, very expensive. In India, it costs lakhs. So it is, and not only that, I think the biggest problem over here is that once again the basic underlying cause is not addressed. Just you are, uh, giving a stamp of technology without addressing hyperinsulinemia, which is the root cause. So this is what a typical fertility journey for a patient with PCOS would look like. They have women with PCOS and obesity have, we already know that, a 56% lower chance of ovulation. So after a year of trying, only 50% is successful, and this leads to a huge psychological turmoil. Metformin and spironolactone cannot be used in pregnancy for many reasons. Clomiphene becomes the first choice medication, but after 6 months, the chances of a live birth is only 22%. Letrozole or gonadotropins fail most of the time, and not to mention the side effects. And then you are left only with intrauterine insemination and IVF. In some cases, there is a happy ending, but in most other, the story just ends in tears. So this is what happens when you just use medicines and technology without getting into the root cause. So, okay, we are starting the polls, Vijita. I have the questions on my screen also. You can.
Yes, sir.
This is question number 1. So I've just so far illustrated the medicines, medical treatment, and the problems with that. So we'll have a poll. Question number 1. Women are required to exist between two cultural worlds and to move seamlessly between them. They must take on the responsibility of being a modern in our country, that is, without foregoing the traditional. Therefore, increased opportunities for middle class women place additional burdens upon them and expose them to new aspirations while circumscribing their ambitions. Is this true? This is from that social medicine study which I showed you.
Okay.
Just about 5 seconds.
I think it's almost 100% is yes.
Of course, yeah, it is true. Just to focus on the problem.
Right.
Okay, shall we move on?
Yes, sir.
Question number 2. This is what I know some of the women have reported when they were interviewed in that study, that we end up eating junk food. Our grandmothers and mothers would not even consider bread as a food. It was always roti in our house. Now we only want bread for breakfast, and there's no time to make rotis. Yet others have spoken that there's no proper eating time and that food timings are not proper. And others have said in an interview that PCOS has a lot to do with stress and a lack of routine life, including sleeping late at night and not having meals at regular times. So, do you think all these changes contribute to PCOS? Yes or no?
So here also we are getting yes.
100%.
100%.
Fantastic. Yeah.
Yeah. So we
I'm
can
just drawing the picture and getting it into focus. So, question number 3: do you think that getting healthy, eating, exercise, and adequate sleep, that is healthy eating, exercise, and adequate sleep, are impractical in the present day lifestyle?
Okay.
That getting word should not be the wrong English. Anyway, healthy eating, exercise, and adequate sleep, are these impractical? Anyway, we have a very fast lifestyle, running
Yes.
from morning to night. So, how practical is healthy eating? How
So
practical is exercising?
almost 50% is saying yes and no is
I
50%.
know. I know.
So yeah.
Yeah, it is. not very practical, may not be practical given the circumstances, because most of us are caught in the rat race. We have to compete, we have to fulfill our roles, and yet we have to remain healthy. It becomes very difficult, isn't it? Okay, so next question, last one. So if you have to choose, you have to choose, I mean, you cannot say both. Just one method, what would be your choice for treating PCOS? As a doctor and as a patient, what would you choose? Medicines, or would you choose nutrition and lifestyle correction if you want a life without medicine?
I think nutrition and lifestyle correction is 100% here right now.
Yeah.
It's changing again.
I have not in case of PCOS, but in diabetes, I have heard people saying that it's too much. I can't do all those things. Just give me some medicines, I'll be fine. So that one might be. I'm not being unkind to that person. It is just that he or she might be forced to take that stand. So
Medications, I think 10% is saying medicines and
yeah,
90% is saying nutrition and lifestyle.
yeah, that is very good. Actually, people are ready to give it a try.
Yeah.
And my entire campaign has been towards that. That if you get your nutrition and lifestyle right, you may not even need the medicines. So it is certainly worth trying. Okay, so that is what I just wanted your involvement and give you the picture. Once again, that study, which is, this is a wonderful study which all of you should go through. So this is what women say, about when they are interviewed. That is, it's just not the ovaries. It affects my entire being, my self-esteem, the way I think, whether I feel positive or negative about myself, my body image, everything. So they say we gain weight easily, and however much I try, I my best, I'm unable to lose my weight. So there are mood swings, depression, and when they try to conceive, they realize that it is very complicated affair. Why should somebody have to try so hard to conceive? you know your bodies are such wonderful machine that it should be a very natural thing. What has gone wrong with nature that fertility has become such a huge issue? It also is very expensive, and there is no definite cure for it. That is what all the doctors tell you after some time. I know many ladies have been told after some time that there's not much that we can do. You have to learn to live with it. You have to learn to live with your birth control pills. You have to learn to live with growing fat, growing obese, having diabetes, having hypertension, having fatty liver, and all the problems. So that is what makes it, a curse for no reason at all. I'll tell you why. So treating fertility, it is actually a very important part, one of the most important part of addressing PCOS for many women. Yes, IVF and other fertility treatments can get you a baby, but because you still have the underlying hyperinsulinemia, you will have not improved your own health, and you may be putting the health of your future child at risk. This is for people who want to go in only for medicine and invasive treatments. So this is the problem. Unless you address the real cause, you're not only putting your own health, but the health of your child at risk. So this is seldom appreciated, that the pregnancy of a woman with untreated PCOS is still at significantly higher risk of complication than normal pregnancy. A pregnant woman with PCOS has increased risk of miscarriage and maternal complications. This must never be forgotten, and one must always be in the alert. But worse is that the developing fetus is also at risk. For example, it could be large for gestational age, and which could often lead to the need for the delivery by cesarean section. And moreover, the environment in which the fetus is growing also makes it vulnerable for its own future. For example, if hyperinsulinemia remains during pregnancy, so the fetus also gets used to that hyperinsulinemia, and this can lead to future metabolic problems, including PCOS if it is a female child. So if female fertility is the complicated orchestra of hormones, as I told you, then insulin is the conductor. These abnormal crescendos and decrescendos of fertility hormones throughout the menstrual cycle, including estrogen, just following the conductor. And if a woman is able to get her insulin under control, often the fertility hormones will follow. And the most common forms of infertility, as we just outlined, like a bad song, can be turned off. This is from Dr. Benjamin Bickman, showed you last time. Now, another very important thing to remember is that PCOS is a disease of low-grade inflammation. This means your body is on fire. There is inflammation all over the body. And that is what is so important. That studies have shown that women with PCOS have elevated levels of specific inflammatory markers. The low-grade inflammation triggers the polycystic ovaries to produce androgen and is a key contributor to the pathogenesis of the PCOS. It's also linked to insulin resistance. So if your body is on a slow fire throughout and slowly and it is inflamed, none of the treatments which are given to you is going to work. So this is once again the bigger picture. This is the hyperinsulinemia, which has to be addressed, and addressing all this through medicines are always very full of danger. So what is causing this high insulin? It is a insulin raising diet, and this is what has changed in our country in the last 25, 30 years, and that is where the metabolic diseases, all the metabolic diseases have gone up, including PCOS. So not only insulin, this high insulin not only gives rise to PCOS, but also gives rise to obesity. And obesity, mind you, is a very important factor as far as PCOS treatment is concerned. So that is why the doctors tell you, lose some weight, because studies have shown that even a small amount of weight loss, 5 to 10%, significantly improves all aspects of PCOS, including menstrual irregularities, anevolution, all these metabolic markers. But the problem is how to lose weight. So the classic advice given is eat less and move more, and to calculate calories in and calories out. And so you must burn more calories than you take, and that is what is going to make you lose weight. So if you have attended my previous webinars, especially the second one, which I talked about obesity, you will know that if you haven't done, please go back and to HCP forum, log in and attend. That this simply does not work. So for that you have to understand. I'll give you a gist that why do we get fat? This is what modern medicine has not understood. That obesity is a hormonal disorder. It is not a caloric imbalance. This eat less and exercise more does not work. All the studies which were done with eating less and with exercise more, all of them failed. That is because the insulin resistance is the root cause behind PCOS and obesity, and that needs to be addressed. The body actually is like a clock. It has a set weight and will fall automatically into place once your metabolism becomes normal. So you have to address your metabolism, address your insulin. Your body weight will automatically fall into place. And if you even go by the mainstream guidelines, this is from ADA, American Diabetic Association, to lose weight, a low carb or a very low carb diet is a viable option. So this is not what I am saying, but what the American Diabetic Association has put into their guidelines. So is there a better solution? Can we address this diet problem, which is giving rise to high insulin, which is giving rise to all these problems? Yes. So once again, these social science studies, it is wonderful to see that in Mumbai, all the doctors, endocrinologists, gynecologists, dermatologists, dietitians, homeopaths, vaidyas, all of them identified unhealthy diet as one of the main causes. Yes, they have identified that the disease has gone up, but unhealthy diet, yes. So they're very much in focus as to why things have gone wrong. Okay, so I always keep on reminding and everywhere, wherever I speak, that medicine is not healthcare. Medicine is sick care. It is food which is healthcare, and we have forgotten that. In the quest of looking for a pill for every ill, this has happened. There is a reason behind this, which I once again always say, that we have come from an era of antibiotics, where there were a lot of bugs or germs and bacteria, and we used to give antibiotics to work like magic. So with that thought process, we try to apply that to modern day metabolic diseases. It simply doesn't work. So food is healthcare. So what to eat? What is advised is a very low carbohydrate, less than 20 grams per day, moderate protein, and high healthy fat. So this is what is known as the optimum insulin lowering diet. So what are the principles behind that? You severely restrict added sugars, severely restrict refined carbohydrates, particularly grains. Uh, your dietary protein should be moderate. A low carb diet does not mean high protein diet, mind you. Eat natural fats liberally. Eat real food. Eat real food means food which is you get from nature. You cook it and you have nothing that comes out of a packet, and nothing that your grandmother would not recognize as food on the table. Avoid refined vegetable oils as cooking medium. The so-called with seed oils, which are heated at 1200 degrees centigrade and put and refined and marketed as heart healthy. So these are direct inflammatory agents. We'll have a full session on that someday. Now, this particular approach of diet to treating metabolic disorders is known as therapeutic carbohydrate reduction. So this is a module of treatment which has been developed by nutrition scientists and doctors worldwide, and it is there. A lot of research has been done, a lot of results are there, but by the time it comes to textbooks and doctors start prescribing, it may take a decade. Medical science is very slow to change. Till then, we believe that millions of people will suffer unnecessarily. So I'm giving you the knowledge well in advance. This is known as therapeutic carbohydrate reduction. It's very much scientific, very much evidence-based. Whatever level of evidence you want, the doctors want level 1 evidence, randomized control studies, all are there to support therapeutic carbohydrate reduction. So I'll show you a few studies which support the fact that this state of nutritional ketosis, which I told you about, and this can reverse the metabolic syndrome in general. So this is what I told you in my previous seminar also, that human beings have evolved with a capacity for metabolic flexibility and to use ketones as a fuel. We can not only use carbohydrates or glucose as a fuel, we can also use our bodies like a double engine. So this is the key to address metabolic disorder. And as far as the PCOS is concerned, here is a study showing the effects of a ketogenic diet in overweight women. So there is a significant decrease of LBM, is lean body mass, and a significant decrease in glucose and insulin blood levels. When HOMA-IR insulin resistance, which comes down, significant decrease in triglyceride, cholesterol, LDL. So all parameters of PCOS were taken care of by ketogenic diet. Most studies, low ketogenic diet and obese women, and they found that significant improvement in weight, free testosterone, and LH, FSH levels over a 24-week period. So more and more studies are actually coming out where ketogenic diet, a low carb, high fat diet is being tried, and it is giving a success. And the reason for success behind this diet is because it addresses the insulin levels. So once again, 8-week study. So I'm not going into the details, just to let you know that there is enough evidence to support what I am telling you. So for a PCOS, not only what you eat is important, when you eat is also very important. So what I'm going to tell you is that you follow a time restricted eating. That is, don't eat throughout small meals throughout the day as many people advise you. It really doesn't help. Remember that a snack is an emotional event. It is not a nutritional necessity. And there's absolutely no such thing as a healthy snack. However healthy food you eat in between meals, it is going to spike your insulin. So, for example, this particular study which looked at 50,000 adults, they found that the more they ate, however healthy, that is more number of times they ate, the heavier they were likely to be. So eat your meals early in the day. That is good for the circadian rhythm, and that is give it a time, give some adaptation period. And this is another study, Matador, which is a randomized study, which IF means intermittent fasting versus a constant fast. And if you do intermittent fasting, it actually helps you more than if you do a constant fast. So early TRE means early time restricted eating improves insulin sensitivity. So there are many studies to support that. And about intermittent fasting, this is the very good review article which I talked about in my previous webinar, number 3 it was. And if you want to know details about fasting and how it reduces insulin levels, you are requested to go back and watch my webinar number 3. But let me tell you just a few lines that it is much more than weight loss. It basically addresses your entire metabolism and makes it fall into space. When you fast, your body switches to fat as a fuel and it breaks down into ketone bodies, which I showed you last time, that your insulin levels fall and your body burns fat, which liberates ketones, and ketones have a fantastic effect all over your body, including inflammation, which is a hallmark of PCOS and all these things, of course. So it promotes cellular health and gives you so many benefits, increased express. And what I would like to focus is that there is a down regulation of inflammation also. So this is a question which somebody asked me a few days back. If you are, if fasting is so good, would you advise fasting during pregnancy? The answer is no. It is still not recommended. It is a big no. So actually most studies are needed. But what you can do, what pregnant women can do, is that they can avoid multiple meals and snacking. So eat good food, real food, and eat, avoid the snacking in between. So continue with the low carb, which will bring down insulin levels and control hunger. But having said this, there is some very interesting data which I would like to share with you about pregnancy and fasting. So here is data from from the Saudi Arabia, where ladies fasted during pregnancy due to religious reason, or they had to fast because of family reason. So the data is very big. It is around 31,000 pregnancies were included. Of 18,000 were exposed to Ramadan fasting. So this particular data shows that the Ramadan fasting had no effect on preterm delivery. Means the deliveries were normal and does not affect the birth weight of the baby. Very interesting. And this another data set shows that this is even more interesting. They showed that women who do fasting during pregnancy in these particular this religious fasting, the incidence of gestational diabetes was pretty low. So that is very interesting to note. But yes, it's not recommended. Just interesting data which I wanted to share with you. Okay, some practical advice and tips which comes from various good doctors and nutritionists is they say that you eliminate added sugars, eliminate sugar sweetened beverages, all kind of soft drinks, and whatever, also the sweet fruit juices, because they contain a huge amount of sugar. Eliminate all processed food. Learn how to watch for food levels. And anything that comes in a package has more than 2 ingredients, it is supposed to be ultra processed food. So you cannot eat that. Avoid artificial sweeteners. Even your, stevia, which many people advise, is not good because the craving for insulin remains. The craving for sugar remains. CPIR means, I told you in one of my webinars that cephalic phase insulin release. So cephalic phase insulin release means that even if you have a sweet which is sweetened with artificial sweetener, you will still have insulin release in the brain. So that is what causes the problem. So your craving for sweets will not go away, and that doesn't solve the problem. Alcohol should be avoided for many reasons, because alcohol will delay the metabolism of all other foods, and desserts you can keep only for very special occasions. So very rare once in a while. I will not say no, but yes, it has to be. You have to be very, very watchful about it. Restrict carbohydrates should be the main aim. So this is what TCR is. TCR is therapeutic carbohydrate reduction. So the first thing is restrict carbohydrates. So you reduce your refined carbohydrates. You eliminate refined grains, products, and products made with them. Most cereals, like starting from your breakfast cereals to whatever you take out, even your oats. So that is a processed thing. If you have to eat carbohydrates, use non-starchy green leafy vegetables and seeds, which has a high fiber content. So anything green leafy vegetables you can eat as a fiber, but nothing that is processed. Seasonal fruits are okay, but no fruit juices, not even made at home. Even if you think that one glass of orange juice for breakfast every morning is healthy, it is not. Because to make one glass of orange juice, you need 10 oranges, and the fructose content is huge. And the problem with fructose, as I told you, is that it is metabolized only in the liver cells, and that can give a huge contributor to insulin resistance and fatty liver. So restrict your carbohydrates to, and once again, let me leave this slide with the reminder that there are no essential carbohydrates. There are essential fatty acids, there are essential amino acids, but there are no essential. The entire nutrient group, your requirement to eat is zero. Whatever little glucose your brain needs and your RBC needs, the body is perfectly capable of manufacturing on your own. So please keep that in mind when you take carbohydrates. Prioritize your proteins. So protein on a low carb diet is moderate. It is never a high protein diet. Many people have this misconception. So choose your proteins carefully. It is a fact that animal proteins are first class proteins and very nutrient dense. And plant proteins are also good, but you have to keep this in mind that you have to make up by eating much more. So legumes are good, but has a higher insulin response. Good animal proteins are broccoli, mushrooms, green leafy vegetables, and combination of these things. Milk has an insulin response and is avoided in low carb diets. And anything low fat which is manufactured and given to you, you must avoid that. Then the third thing is the healthy fats. The fats are saturated fats you get, monounsaturated fatty acid and polyunsaturated. So the idea is to eat more of natural fat which exists in nature, like so most are there could be either from animals or from vegetables, but natural fat and saturated fat are more have omega-3 in them, which is a favorable ratio. And if you have more of monounsaturated, they have more of omega-6 in them. So a healthy ratio is to be maintained. It should be more. If your omega-6 ratio becomes very high, then it becomes inflammatory. So fats have the least insulin response of all the three macronutrients. Always avoid processed fats and trans fats. And avoid vegetable and seed oil once again, because they are highly inflammatory, and choose full fat foods more often. So this I would like to leave this topic with this very, very important study which I told you in my first webinar itself, that something has really gone wrong with fat and fatty acids in our diet. So this was a very detailed study which showed that actually Indian diets are predominantly vegetarian and low in fat. Furthermore, the main sources of fat are of plant origin, and then than animal origin. This results in a diet that is relatively low in saturated fatty acid, high in polyunsaturated fatty acids, and very low in omega-3 PUFA. So actually, on the surface, it sounds very good. Yeah, low fat, more of PUFA, more of MUFA, less of saturated fat. But you have to look at what has happened in our country. Though this appears to be a good dietary composition as per worldwide recommendation, the undeniable increase in the incidence of obesity, diabetes, cardiovascular diseases, and PCOS also, I would add, this begs for an explanation. In this context, this article examines, or rather reopens, the debate on fat intakes in Indian diets. So this is seriously criticized. The amount of fat that we have in our diets is so low that it is one of the major cause of metabolic disorder. So this is what has got, and this article is an eye opener. So once again, the principles of a low carb diet should be to eat real food and eliminate added sugars. Choose low carbohydrate, high fiber, non-starchy. Aim for a diet that is 75% fat, 20% protein, and 5% of unrefined carbohydrates. So eat full meals when hungry and avoid snacks. This could be just a repetition, so just skip over it. So the take-home message would be that the root cause of PCOS is insulin resistance. Low-grade inflammation, mind you, is consistent with the condition. So insulin-resistant and low-grade inflammation. Therapeutic carbohydrate reduction targets insulin resistance and brings down inflammation. Intermittent fasting is one of the most powerful tools to activate the metabolic switch and the body, and also to reduce insulin resistance, and very useful as far as treating PCOS is concerned. Medications will either be temporarily effective or ineffective to tackle the signs and symptoms of PCOS. Unless you address insulin resistance, medications will not work. If the root cause is well handled, you may not even need medications. Okay, so that was my message, and with that, we come to an end of the discussion. Not the end of the discussion, just the beginning of the discussion, end of the slides. So I would like to go back to the webinar room.
Yes, sir.
Sharing. That's it.
Yeah. Yes.
So okay.
I think we don't have any question.
Okay.
Only Mr. Pavitra Mohan Malik has said that I try to treat with nutrition and lifestyle changes, but the patients go back to the junk food they are addicted to.
So actually, sometimes I ask patients who come to me that how desperate are you? Do you really want to live a life without medication? Do you really understand the long-term implications of continuing with your condition? Could be diabetes, could be obesity, could be anything. So I think people have to be made more aware the long-term drastic metabolic catastrophe that could occur. So today it seems very easy to just swallow a pill and get over it. And PCOS doesn't even allow you that. If you are trying to conceive maybe, and you keep on trying, keep on taking medicines, it doesn't work. Even if it works, you have a miscarriage. So the whole thing is a disaster. And even if you are not trying to conceive, how long can you keep on taking birth control pills? Because they also have their side effects. So what is the kind of life where you have to take medicines throughout? So that is what is concerning. And it is, people, it is to accept as normal that medicine is going to be a bunch of medicine is going to be a part of your daily eating program. Is something which our body was not. This is not how our bodies have evolved. We are simply insulting the intelligence of the body by not giving it a chance to to deal with the problems which you are coming across. The body is very intelligent. It is a super healing machine, and all you have to do is to get out of the way, which we do not do. Just swallow some pills and make it worse. So that is my take on the situation. So anybody has would like to somebody wants to speak?
So yes, we have got a request
Mhm.
from Amna Goswami with that
I'm not.
yes,
Oh, I'm so happy
I'm
she's here. Yeah, please, please.
accepting her
Mm.
request,
Yeah.
and she might take to like 10 to 15 seconds to join.
Okay. 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 Okay.
Yeah.
Uh, no problem. Till then, you can. If anybody wants
Yes,
to.
and I think we have got another question
Yes.
that the psychological effect on the patients of PCOS is extreme. Okay,
Yes.
that's not a question. It's a
That's a yes.
yeah,
Extreme. It can completely. It is life. It can completely take away the meaning from your life,
right.
and make you feel that life is not worth living, because it affects so many things. It affects your self-image. It affects your the way you talk. It can lead to depression. The psychological aspect is huge, and to realize that just as something as simple as nutrition can correct it, why wouldn't somebody go for it? I think and if the correct advice is given and the message is spread wide enough, as the polling also showed today, I'm sure everybody will give it their best, right? I'm sure of it. Nobody would say that, I just want to take medicines throughout my life. I would certainly give nutrition a try. I'd certainly allow the body to heal itself. I'm sure of that.
So Mr. Hitesh Singh has a comment that thanks a lot.
Mhm.
How to frame actual diet weekly prescribed by you, and
Mhm.
tests to follow up for evaluation of effectiveness of diet as medicine.
Yeah, actually, it is better not to have strict diet charts. I never give out hand out diet charts. It is more important to understand the principle behind a low carbohydrate or whatever ketogenic diet that I'm talking about. That once you understand the principle, you know that what each macronutrient is going to do to your body. So that way you will form your own diet chart. And how to monitor? You can monitor it yourself, physically and biochemically. If you are trying to lose weight, your weight will come down. If you are trying to bring down your blood sugars will settle. If you are trying to slowly get off medications, due to whatever medications you are taking, whether due to diabetes or hypertension or obesity, you have to work with your doctor, of course. So all these things will gradually settle. So this can be very easily monitored. It can be done in a monthly or bi-monthly basis. There's no need to do it, too frequently. But weight, you can check your weight every month. You can check your pressure almost every week or every day also. So all these metabolic parameters settle down when you follow a diet which is, I would say, is actually meant for human. Human beings are not meant to eat 80% carbohydrate diet. I'm sorry, if it sounds very drastic, but if you look back, not 10,000 years when agriculture was invented, but if you look back 3 million years, this is what human beings evolved on, you know. So their diet was what has made us today. And agriculture was just yesterday. And if you really look at it, if you talk to historians, most of them will tell you that agriculture was the biggest mistakes made by human being. Not only all the diseases, modern day diseases, have started after we invented agriculture, including war, including all kind of infections, including all kind of industrial revolution and all kind of metabolic diseases. Our brain size has also shrunk by 15%. It used to be 1700 grams just before discovery of agriculture. Today, after 12,000 years, our brains only weigh 1500 grams. So our brain size went hugely up when man evolved from chimpanzees to Homo sapiens. So that is when the brain size coincided with the increase of eating in fats. But human beings have a huge brain. I'm not saying that something really good has happened by if chimpanzees have evolved as human beings. Look at the human beings today. They're ready to destroy the planet. I'm not saying that it is good that has happened. Sometimes I think that we should have remained as chimpanzees. But the fact is that if you want to maintain your brain size, if you want to maintain your intellect, you must eat food which is specific for your species. That is the most important thing. Please think about this point. And carbohydrates, as I said, science also tells you, are not essential. So if you keep on eating an essential food, a non-essential food, as 80 to 90% of our diet, things are bound to go wrong. Just as Amnadi joined.
No, I think she has a question here. She has put up the question here.
Sure.
That we have got a lot of questions.
Oh, fantastic.
She said that what is meant by low starch vegetables.
All the green leafy vegetables, starchy vegetables are like potatoes, all the underground vegetables, the tubers, they have a lot of starch. So you go for vegetables which are green leafy and grow above the ground. So you avoid the starch over there.
We have another question from Rishija Bhattacharya. She said that she has PCOS
Okay,
and she does exercise regularly and avoid junk food.
very
And
good.
her period cycle is also normal, but unable to lose weight. So she
Okay,
said that she's trying very hard but feeling demotivated, and she
yes.
has rotational shifts. So
Okay.
that is what she can do.
Yeah, actually, I would advise you first of all to go through my webinar 2, which was on losing weight. So in a gist, I can tell you that this eating less and exercising more will not help. So exercising will help only if your diet is right. So if you are uh, having a lot of say, assuming that you don't eat junk food also, but if you eat a lot of carbohydrates, that will prevent you from losing weight. So if you can shift to a meal which is high in fat and moderate in protein, and take out the carbohydrate, and also I would say if fat loss has become plateaued, you can incorporate a little bit of intermittent fasting. It will really help. For example, the 16 hour fasting period every day, and 8 hour eating window every day. So that will kind of jumpstart your weight loss. So that would really help. Uh,
So
so
we
I hope that answers your question. So just keep your junk food off. Fantastic. So try to incorporate a little bit of fasting. So that might jumpstart. So
we have another comment from Dr. Virappa that it's very
mm,
useful webinar, and I am pre-diabetic and overweight since June 29 first webinar series. I have started intermittent fasting,
mm.
and over 2 months lost 8 kgs.
Wow,
Now I ask on one meal a day for 25 days. So he said it's
fantastic.
great feeling. It helped me a lot. He
Okay.
said thank you very much.
Oh, that's great to know. Somebody has been inspired with the webinars. And please continue. This is just a beginning, not the end. So if once you realize the benefit of one meal a day and the intermittent fasting which it gives you, I'm sure you don't want to go back to your previous lifestyle.
We
Okay.
have got another comment from Pravati Pal. She said that very well explained with evidences from papers. However, there are thousands of publications favoring low-fat diet and the bad effects of fat. So it will take few more years to convince the people about the benefits of low carb and high fat diet. So we
Yeah.
need more publications and meta-analysis favoring this.
Yeah, they are all coming up. There, as of now, in the last 1 year, there has been huge number of trials and randomized control trials and meta-analysis coming up, which favor this particular therapeutic carbohydrate reduction. So we can have a full session on that if you want. Yes, trials are there. More and more studies are coming up and addressing each and every metabolic disorder, not only PCOS, diabetes, hypertension, even cancer. So they are there, and all these low fat studies which have been there, most of them has been funded this by the nutritional industry and by the pharmaceutical industry. So that you have to see who is follow the money, as they say, who has funded the studies and why. So, and initially the entire low fat thing was based on a flawed concept. It so happened that one particular, I will not say nutritionist, he was just a physiologist, Dr. Ansel Keys, I'm sure you've heard of him, in the 1960s did a study known as the 6 countries or a 7 countries study, where he kind of extrapolated or manipulated, or this is known as cherry picking data, and he tried to show a correlation between dietary fat and heart disease. So he collected data from 22 countries, and which was the total did not show anything conclusive. So he picked the 6 countries which matched his theory, and he showed that increase in dietary fat causes heart disease. And he was very well connected with the government, got it incorporated into the guidelines, and there the low fat story started. And because we follow the Western guidelines, it got incorporated in our society also. And look at the consequences. It was a completely flawed study which could not be repeated by the author himself. And because of that study, the 6 countries or 7 countries study, the low fat hypothesis, what has happened is today in our country, a middle class housewife is afraid of eating the yellow of the egg. So that is the level of trickle down which has occurred. So in Western diets, what happened was when you take out the fat, the taste goes away. So we have to substitute something. They do not have fantastic recipes like we have, like our ancient cooking has. So if you take out the fat, you have to put in sugar over there. So to make it a little bit of tasty. So what was done? What was the blame put on? Calories. So you can. So the calories in, calories out concept came in, and the fat was blamed. So everything became low fat, low fat, low fat. And what happened? Instead of the heart disease coming down, obesity coming down, and other diseases coming, it just shot up. And in our country also, certain changes occurred, including the vegetable oils in 90s, and including this low fat thing also came to our country because we follow their guidelines. And these diseases also affected us. So all these things is a part of the story. Yeah.
Mr. Netai Datta said that he has seen 16 to 17 hours of fasting makes body weight constant in COVID
Yes.
time when movement is restricted. So his question is measuring insulin level will tell that intermittent fasting is effective in my case.
It's a bit of a complicated question. See, you can measure your insulin levels if you want, but it's not necessary. If you are doing 18 hours of fasting every day, it's pretty good. Pretty good. Continuing it, you can measure your insulin once in 3 months, like diabetics advise HbA1c. So once in 3 months, if you want, you can measure insulin and calculate the HOMA IR as it is called. So if it is acceptably low, you are fine. And as long as you know and understand the principles of fasting, and you are able to control your hunger, so if you are doing fasting correctly, the very first thing that will disappear is your craving for food and your hunger. So if that is happening, that means you are on the right track. So please continue your fasting. It is a fantastic thing to do. It is a very powerful hormonal intervention to your body. Please don't forget that. So don't think that fasting is just a fad. It is not a fad. It is a medicine which is more powerful than any other medicine to treat metabolic diseases.
Dr. Ritesh had a question before and you explained it. He said that thanks for it. And he said that please keep me updated this approach of diet as medicine. And he has given his phone number also. And he
Okay.
said that will
What is
count
Ritesh? Ritesh, what is his full name?
Dr. Ritesh Singh.
Singh. Okay, sure,
And he
sure.
said that will counsel lots of patients by your reference and case studies.
Okay, okay,
Yeah.
sure. Just keep in
Uh,
touch, and please attend all the webinars from now on, because we are going to address all kind of metabolic issues.
Dr. Virappa has another question that what are best sources of protein and calcium, vitamin D for vegetarian? Is butter
Uh,
or ghee daily we can take? Is it good?
yeah, butter is a very good source for vitamins, and yes, you can not only take every day, you can take to your satisfaction, as I said. I mean, don't have to gobble up, butter sticks, but yes, liberally you can use with your food, and you can have along with to your satisfaction. But butter will give you the satiety that you need, and it is a very good. I would say it is a health food. Don't be afraid of butter. You can combine it with food. You can have it by itself. Even put it in your coffee. Butter coffee.
We have another question from Miss Molly Thambi that she's been on intermittent fasting with one meal a day for the
Hmm.
last 6 months, and
Fantastic.
lost I think 6 kgs. But last 2 months the scale hasn't moved. I have
Okay.
PCOS, hypothyroidism, insulin
Okay.
resistance.
Okay. Okay. Could be that you are a bit of a severe case. So don't lose patience. One meal a day, and please look into what that one meal a day contains. Okay, maybe you can be a bit of tweaking there, cut down on the carbohydrates over there, and go up on the fat. That and so give it some more time and see how it behaves, I would say. And if required, you could once in a while do an extended fast also. 24 hours once a month, maybe do a 36 hours. So that will what will happen is your weight loss will be jump started. You'll have more weight loss, and that will help the other symptoms of PCOS. So but make sure that you plan it and do it, and you don't feel hungry, and and so before an extended fast, I would say eat plenty of healthy fat, um, so that the fat satisfies your satiety center very fast. So that will keep you going throughout your extended fast. So I would advise you, if you are doing one meal a day, please continue doing it. Fat loss is very, it doesn't happen like this. It doesn't happen in a constant downward pattern. It comes down and then there is a plateau, then suddenly comes down again, and then goes in a plateau, then suddenly comes down again. So this is known as a we call it a whoosh effect. Suddenly whoosh it comes down. So the fat cells, they start converting into ketones, then suddenly they shrink in size. So keep going, keep doing your one meal a day. It is a fantastic thing to do. And if possible, only if possible, if you feel comfortable, give it an extended fast once a month and see what happens. So And any problems, please refer back.
She has another question that if having carbs or grains once or twice a week will take away the benefits of my fasting.
See, normally it should not, but it all depends on how severe your condition is. If you have a goal to achieve, a goal to reach, then the principles have to be followed strictly. So that is where your motivation, your willpower, your determination will play a role. So if you are motivated enough to say that, yes, I will deal with this, I will do my best. So you can avoid. Actually, once again, your motivating bottom line should be, it's not necessary for my body. So if it's not necessary, why am I taking it? That means it is an emotional thing. It is an addictive thing. Most of us are addicted to carbohydrates right from birth. So it's very difficult to conquer for anybody. Even I will not say that I have conquered it. But if you keep that in mind, it really helps you to get closer to the goal. So if uh, you are motivated enough to deal with whatever condition you have, I would say avoid it. And especially in this manner of eating or way of eating, as we call it, there are no cheat days, because a cheat day will set you back, and by the time you get back get your body to burn ketones again after a carbohydrate meal once a week, it will be another 3-4 days. So then throughout the week you've got just 2 days left. So it's really not all your hard work will be will be negated if you just have a cheat day, or if you have well, you have to take a call on that.
We have another question from Dr. Virappa, that best recommended journals for nutrition, health, and intermittent fasting.
Recommended journals. See, there are no separate journals. There is one journal called Nutrients, which brings out a lot of articles. I can share with him. I have his number. And then there are journals, proper mainstream medical journals, which nowadays are more and more often publishing full review articles and randomized control studies. For example, about fasting, please refer to the NEGM review article, which came out on December 26, 2019. And I have talked about it in detail in my webinar on intermittent fasting. So that is a summary of all the studies from the bibliography of that article. You can go into hundreds of other articles. So that would be the starting point, I would say.
Dr. Amna Goswami has a question that the fasting during Ramadan from sunrise to sunset for a month. So how good is it health-wise?
All the studies that has been done in Ramadan, other than the PCOS or for anything, initially I mentioned it in one of my webinars also, have shown beneficial effects. This particular fasting, which is done, maybe the reason is religious, but the benefits are immense. The subjects who did this, people who did this, not only had weight loss, but improved on their metabolic parameters. So this is religion with a solid scientific base. Fasting really helps. And mind you, this is not a very extended fast at all, because in Ramadan we eat before dawn, before the sunrise, and then we eat after sunset. So it's just about 12 hours to 13 hours. That's it. And there is not much of restriction on what we eat before and what we eat after. Even then, the benefits are very, very tangible. So imagine if you extend the fast and you eat according to the principles of addressing the insulin, how much more beneficial it is going to be. Yes, certainly it is very beneficial.
And sir, I think we are done with all the questions.
Okay, that's
So
great.
I think
That's great.
Ms.
And
Molly has replied that thanks, got the funder clear of no cheat days.
yeah, no cheat days.
Hmm.
So let this not be the end of the conversation. And I've given you my details. That is the beginning. And if you have any queries, questions, you want to know more, you can always ask me on my Facebook. I have a group by the same theme, sorry, by the Facebook page, that are you as healthy as can be. So you can join in and keep the conversation going, and also make it a point to attend these webinars on every week whenever I'm on. I'm live on HCP forum, so that will help you to keep in touch and stay in touch. Thank you very much.
Thank you
Happy
very much,
Teachers
sir.
Day once again. Yeah,
Yes, happy Teachers' Day to you also. And I'll again request everyone to give their feedback.
yeah. Please, yeah, feedback is
Please.
very important.
Yeah.
It will help us improve and on the webinars.
Thank you
Thank
very
you.
much, sir. We can
Thank
wind
you.
up here.
Yeah, and good
Yeah.
night.
Thank you and good night.